A couple disclaimers. I'm definitely biased. I'm going to say that perinatal quality collaboratives are awesome, all right? And I'm not trying to present a fair, unbiased look at it. This is my opinion, and I'm going to try to convince you of that. A lot of what I'm going to talk about is based on what we do in Massachusetts. Obviously, PQC has been driving this field for a long time, but I'm going to share with you mostly what we're doing in Massachusetts. It's mostly neonatal focused rather than OB and neonatal. And there's a lot that we can talk about PQCs, so I'm going to try to cover a fair amount, but there's even more about PQCs that I'm not going to try to cover. So this is just kind of a little survey. QI, quality improvement. It's a formal approach to examining performance and a systematic approach to improving it, right? So we all want to take better care of our babies and our moms and our families, but what QI says is let's be systematic about it. Let's think about how we're doing, measure how we're doing, and let's be organized about how we try to improve that. And why focus on QI in healthcare? Why is it important? You know, one way to think about it is this model that was written by Paul Batalden and colleagues a number of years now. If our goal at the end is better care of our patients, right? So that's on the right side, measured performance improvement. There's two things that go into that, at least two things. One is generalizable scientific evidence. We need to know how to take care of these patients, what the disease is, what the treatments are. And that's a lot of what research has done for us. Over the last 20, 40, 100 years, our research has led us to better scientific knowledge about diseases and treatments. But more and more realizing this middle part is also critically important, and that's the context. It's not enough just to know what a disease is or how to manage it. We need to make sure we're taking that knowledge and bringing it to the bedside in a reliable, consistent, and organized fashion. That's the context of care. And that's what QI does. Quality improvement looks at that middle piece. This is somewhat simplified, but you can say research tells us what we need to do. QI makes sure we do it in the right way. They went on to say, this framework means that everyone in healthcare has two jobs. So if we're a provider in healthcare, we have two jobs when we come to work. We need to do the work. We need to take care of the patients. But we also need to improve it. We need to work on that middle part of applying our knowledge in the right context to do an even better job of taking care of those patients. So there might be researchers in some areas, there might be clinicians in other areas, but QI extends to everyone in healthcare, at least what these folks claim. And I agree with it. All right, so why else QI? This is a graph from my hospital. This is admission hypothermia in very low birth weight infants. We're all perinatal providers. We all know this. Very low birth weight infants, if they get cold in the delivery room, that's a bad thing. That's associated with all sorts of adverse outcomes, both short-term and long-term. So this is our rates of the babies that were cold in our NICU from 2009 till a couple years ago. And you can see we got a lot better, right? Back at the start, 50, 60% of our babies were cold. Now 10% of our babies are cold. And how do we get better? Not through rocket science, not through big dramatic changes, just by being a bit more careful about what we're doing in the delivery room, keeping the room warm, using the plastic wraps, making this a priority for folks, right? So this is great. This will, you can say, look, we're a lot better. It also makes you think, man, we were terrible back then. How are we letting 50% of our babies get cold, right? But this is QI. This isn't new research, new knowledge. This is just quality improvement, making these outcomes dramatically better. And this is seen in numerous areas. An international network of NICUs that tracks outcomes. This is a recent publication where they looked at several different outcomes. Late onset infection on the top left, necrotizing enterocolitis on the top right, IVH bottom left, and ROP on the bottom right. You can see for all of these things, some a little more dramatic than others, this is over a 10-year period, these rates have declined across their whole network. So across 1,000 NICUs, these outcomes have been getting better. Again, why are they getting better? Maybe some of it's new research, some new knowledge, but most of the improvements are almost certainly due to just better care, quality improvement, taking a bit of a closer look at what we're doing. And then my last point about this, so Alan Spitzer from NAS from Pediatrics wrote an article a couple of years ago where he asked, has QI really improved outcomes for babies in the neonatal intensive care unit? And he put this graph up of neonatal mortality in the U.S., 1990 to 2011. And he argued that you can kind of see three phases of improvement of neonatal mortality in the U.S. This first phase This is 1990s, the second phase in the 2000s, and then his third phase in the more recent time. And his argument was phase one, probably those improvements were due to new research. So big new ways of caring for babies that were implemented back then. Antenatal steroids, surfactant, right? And probably those are the big things that led to changes in mortality. In phase two, it was flatter, maybe a little improvement, but not a lot. But now we're seeing an improvement again. And his argument is in phase three, there haven't been big dramatic changes in the care we're providing. Phase three, the improvements are probably due to quality improvement. People paying more attention to infections and neck and breast milk and BPD. So he also is arguing that QI now more recently is what's leading us to the bigger changes, the bigger improvements we're seeing in the care we're providing. All right, so that's just a quick little snapshot of QI to try to convince you, if you're not convinced already, that QI is important. It's something we should all do, and it's something that's making a difference. And PQCs are now a thing. There's this national network of PQCs that Brenda mentioned, and she showed this map that shows most states have a PQC. The different colors here reflect CDC's involvement with the PQC, whether CDC is one of the supporters of that state PQC. You can see Tennessee does have some CDC report. I will tell you, if you don't know already, TIPQC was one of the first of these PQCs. This is a list back in 2009. So in the 2006, 2007, we had this informal group of state collaboratives getting together. TIPQC was there from the very start. This was 8 PQCs. And this eventually grew to this national network of PQCs once the CDC got involved. But TIPQC was there from the start. All right, what do state-based PQCs do? So if our goal is to improve maternal and newborn outcomes, that's the common goal of all PQCs, I'm going to suggest that there's lots of different things that PQCs do. I'm going to offer you one framework. This is kind of the way I've started to think about it. That there's 5 activities that PQCs can do. There's more, but this is one way of breaking it down. 1 is QI education. 2 is supporting local QI efforts. Those first 2 I'm just going to talk about for a minute each. The third is benchmarking. I'm going to spend a few more minutes talking about benchmarking. The fourth is collaborative QI projects. That's kind of the holy grail. That's really what PQCs want to do. And the fifth, we're starting to get better and better at this, and that's making a difference at the population level, kind of serving as a population level improvement organization. So let's go through these things. The QI education, if you're newish to QI, it sounds like a lot of us are not, you know that there are QI tools that are important. They're rigorous, scientific tools, and it's important that we use them. Whether it's the model for education, the model for improvement, key driver diagrams, run charts, control charts to look at data. You guys are doing all of this. You even have this awesome website. I don't know if you know this, but your website's used by people everywhere for QI education. This just-in-time training where you list all these QI tools and offer like a half-page, one-page overview of that tool. If you guys haven't seen this, you should look at it because people across the country are using it, and it's a great resource. So QI education, even though QI is now, we know how important it is, there's still a lot to be done to just teach us how to do QI better, and that's one thing PQCs do that's important. The second, supporting local QI efforts. And then this isn't that hard. This is just getting people in a room together to talk about what they're doing. At our first NeoQICs, our state collaborative in Massachusetts, that's our neonatal collaborative in Massachusetts. For our first several years, all we did at our meetings was get together and share projects. So we heard about kind of projects to reduce ROP or to reduce Lyme infections or improve CPAP delivery, reduce IVH, optimize growth, admission temperatures. And there was a lot of value in that. Just getting people in a room and saying, hey, what are you doing? What are you doing? Giving feedback. Even before we started thinking about collaborative projects, just hearing about local projects had a lot of value. Now, at our meetings, we have poster fairs, very similar to what you guys are getting set up for this afternoon, right? Giving people a chance to present their work and hear back from them, a lot of value. If all PQCs did was bring together hospitals from across the state in a venue like this to share their projects, that would be value added to what we're doing for moms and babies, if that's all they did. I will mention one more piece of this supporting local QI, that for us, we just got into this in the past year or two. I think TIPQC was one of the first people to do this, and that's site visits. I like the idea of bringing hospitals together to share. In the past 2 years in Massachusetts, we started doing site visits where we go to hospitals to see what they're doing firsthand, and we bring different teams with us. That has a lot of value. To hear about a project in the poster is one thing, to go and see them in action, particularly around this opioid work, it really opens your eyes. That's a new ways of approaching care. So these site visits for us have been very valuable. I think PQCs have been doing site visits for a long time, though. Right. So that's just real quick on the first two things, QI education and supporting local QI efforts. Let's turn to the next couple activities, which are a little kind of more substantial. So benchmarking. So we already saw a couple examples of benchmarking. When Brenda showed us those national maps where every state was compared to others, that's one type of benchmarking. But what it is benchmarking compare performance to external standards. All right? And it's typically done with data and measures. Those report cards are done with state-level data. You can also do it with practice surveys. I'm going to give you an example of that. And I'm going to make the case that benchmarking within a state PQC is actually better and more impactful than benchmarking within a national network. Most of the times our benchmarking is national. You know, we get our performance compared to Vaughan or to CMS or to the CDC NISN rates. And that's great, that's the starting point. But benchmarking within a state PQC, I think, is even better. All right. So for the neonatologists out there, or the neonatal providers, you've probably seen Vaughan data. If you haven't, you should take a look. I'm sure many of your NICUs are members of Vaughan. Within neonatology, that's certainly the biggest benchmarking service that we have. Data from thousands of NICUs, you can see your performance compared to that big network. So this is my hospital. This is Vaughan's new data platform. You may not be able to read this, but across the bottom, there's 6 or 7 different metrics. Any late infection, chronic lung disease, PVL, death or morbidity, mortality, NEC, IVH, and ROP. And what Vaughan will tell you is it gives you a dot for your performance, and it compares that to the Vaughan network. That box is the Vaughan network. So if you're in the middle of the box, then you're kind of on par with other Vaughan units. If you're above the box, you have a higher rate. If you're below the box, you have a lower rate. These are all bad outcomes. You want to be below the box. You can see my NICU, we're kind of in the middle on most of the things. NEC, this was, I think, last year, our rate was a little higher. So that's good information. It makes us want to go look at those cases and see if there's something we can learn from our NEC cases. And PVL were pretty low. So this is useful. It gives you a little snapshot. But what if you took those same outcomes and compared themselves, and instead of a national comparison, you did a state-level comparison? So this is Vaughan data just for the NICUs in Massachusetts. In Massachusetts, we have 9 level 3 NICUs. So we have a bunch of level 2s, some level 1s, but 9 level 3s. This is our Vaughan data for those 9 level 3 NICUs, chronic lung disease. And you can see some hospitals are down at 15, 20%, some are 25, 30%, some are 40, 45%. My NICU, I think we're right there, right in the middle. When we looked at the Vaughan data, we're like, yeah, we're average, not a big deal. When we looked at this, we're like, wow, there's 3 units down the street from us that are a lot better than us at chronic lung disease. You know, this drove us a little more to look at this and say, maybe there is some opportunity for improvement. In Massachusetts, we went one step further. So we had this Vaughan data. We kind of, Vaughan would give it to us, de-identified. So we knew that we were hospital E, for example, but we didn't know who the other hospitals were on this report. We said, look, if you want to really be a collaborative, we need to be a little more transparent. We need to know who the other hospitals are. So we agreed to share, to identify ourselves within our collaborative. So now our reports in our state, we have the hospital names across the x-axis, not a hospital code. I'm going to show you a couple graphs just for the codes because we kind of agreed externally we'll keep the hospitals coded, but internally at our meetings we identify ourselves. And then you can start making graphs like this. This is chronic lung disease, the last few years. This is a control chart which just puts some statistical limits around those rates. You need the sample sizes in order to do that. But this tells us among our 9 NICUs, we have 2 NICUs that statistically have significantly lower rates of chronic lung disease than the other ones, and a couple NICUs that have statistically higher rates than the other ones. When we're in our meetings and we have our hospital names up there, this drives a lot of conversation, and this drives a lot of improvement efforts. Here's a practice. This is nasal ventilation. So this is another Vaughan measure. So this was an outcome, chronic lung disease. This is now maybe a process measure. What is the use of nasal ventilation? This means NIPPV, so CPAP with some extra kind of breaths on top of that, right? This is pretty dramatic. So we have nobody who's in the middle. So 4 units use a lot of nasal ventilation, 5 units use very little. There's something we learned there, as we start teasing into why people use this, why they don't, and how it ties into outcomes. You can also benchmark with practice surveys. So that's benchmarking with data, right? Like actual rates of outcomes or processes. Several years ago, at the start of our NAS project, we just did a practice survey. I'm sure you guys are doing similar things. I think they were doing one out front. So we asked a number of questions. One of them was, do you routinely monitor infants with NAS, meaning on a cardiac or oximetry monitor? And most of the hospitals said, yeah, we put them on a cardiac monitor or both. But 6 hospitals said no. This is actually 5-6 years ago now. And these hospitals were like, how do you not monitor babies with NAS? You're putting them on morphine. You have to monitor them. And these 6 hospitals, which are largely level 1 hospitals, they're like, we never have. It's been like 15, 20 years we never have. And we don't have a space to monitor them. The babies do just fine. And what was impressive was knowing this allowed a lot of these hospitals to rethink whether they needed to do this monitoring, which allowed them to rethink whether these babies needed to be in the special care nursery or NICU. And we saw a big shift over this time of hospitals caring for babies moving from an intensive care monitored setting to a non-intensive care unmonitored setting out on the ward or in the nursery or in the mom's room, which you know as well as I do, that made a big improvement in the way these babies were cared for. And this was just through a simple practice survey. All right, so benchmarking, my opinion. Comparing yourself to national benchmarks is a great start and it's important, but comparing yourself to your state peers is much more compelling. And if you can be transparent, if you can agree to say, all right, we'll let each other know who we are and what our rates are, that dials your benchmarking up to 11. All right, hopefully this is making sense. Sorry I'm going a little fast. I know time's a little tight. But so let's turn to the fourth thing. So QI education, supporting local QI efforts, benchmarking, and then collaborative QI projects. And that's always been kind of the primary goal of these PQCs, to bring teams together to do joint projects. This is an article from 2 years ago that lists a bunch of state collaboratives across the top. Across the left are different projects, and then check marks is whether those states have worked on this area, on this project. And the different projects, antenatal steroids, antimicrobial stewardship, vital statistics and birth certificate accuracy, infections, congenital heart screening, delivery room management, reducing early elective deliveries, duration of stay, breastfeeding, and NAS. Tennessee is right there. And if you count up the check marks, which I did, you guys have 7 of these. No other state has 7. Actually, California does. Every other state has less than 7. How do quality collaboratives do collaborative QI? I'm not going to get into this too much, but most of our state PQCs use something kind of that's based on this IHI breakthrough series. So this is QI methods for collaborative QI. And it's not rocket science, but IHI kind of formalized this. And what they suggest is you get your team together, you select your topic, you get your faculty, you get your hospitals involved, and then you have meetings, learning sessions they call them, much like this, where once in a while you get your teams together, share, learn, and in between, the teams are at home doing the improvement work, doing PDSA cycles, making that improvement. You get back together, you revisit, you learn, people go back and do that work, right? So most collaboratives work in some model based something like this. Recruit teams, get together, people do work back in their own centers, get together again, share and learn. The quick side note about these teams. So in Massachusetts, like in PQC, like in other PQCs, the heart of the organization is hospital-based teams. Right now, PQCs have lots of different partners. Brenda listed so many other partners that are critical, but at the start, it's based on these hospital-based improvement teams. This is a survey we did at the start. This is, again, our NAS project, to ask our teams, who's on your team? Like, what type of disciplines on your team? Nurses on every team. Attendings on most of the teams. NPs, social workers, OTs, PTs, pharmacists, getting a little less, but still pretty good representation. You can see patients or patient family members. At that time, there was only 2. This was several years ago. Luckily, we've gotten better at that. I think we've learned from you guys and other states that that's got to be a bigger focus for us, and we're finally getting better. But I would ask you, what other organization gets teams like this together to do projects, right? And even in this room, for the diversity in this room, nurses, and docs, and family members, I don't know of any other kind of statewide group, organization that brings together this kind of community from so many different hospitals, so many different disciplines to work together towards a common goal. That's a huge value of PQCs. In our NeoQIC, in our state NICU collaborative, even more than just involvement, the leads for the different projects have been very diverse. So for our CLABSI project, a lot of the team leads were NPs or nurses, of the people leading the line teams, the central line teams in those NICUs. For our Safe Sleep project, nurse educators became the leads at most of the teams. For the Human Milk project, we had nutrition leads and lactation leads. For NAS, docs and nurses both. And for respiratory care, we're just starting a new project around respiratory care and BPD. We have docs as team leads, but now a couple teams have RTs as team leads. So it's a great chance to bring together so many different disciplines, not only to be part of the team, but to even lead the work. All right. And then the last thing about collaborative QI with PQCs, so we know for single center QI, we use the model for improvement, aims, measures, changes, PDSA cycles. For collaborative QI, the way to do a joint project, here's one approach. You select a common aim, everyone says, all right, our goal is to improve the care of moms and babies with perinatal opioid exposure by decreasing the rate of foreign therapy by 20%, whatever it is, a common aim. I think for collaborative QI, common measures are important, and you guys have this. You need data sets that you all agree to collect and share, because that lets you do that benchmarking, to see performance across your state, but also between your hospitals. The changes don't need to be that common. They can be. You can say, all right, here's a toolkit. Here's something on non-farm care. Let's all work towards this. But the changes might also be local. Like the way to get better breastfeeding rates in one hospital may be different than another hospital. Then most importantly, what PQCs do for these collaborative projects, you take that data that you're collecting and you use it to drive improvement. I'm sure your hospitals like mine, we collect a lot of data, but we don't use it. We don't put it back in front of the people at the bedside. We don't make it into reports that can be useful. And that's what PQCs can do. They can take that data and use it to drive improvement by giving it back to centers in a way that's useful and productive. And I know that's what PQC does, and you've been doing it for this whole time. All right, so does collaborative QI work? Well, one way to answer this question, let's look at the publications. If you do a little Pubmed search and look for publications by state PQCs, this is by year, 2009 to 2019. You can see every year there's a nice increase in the number of publications by PQCs. This isn't the end-all be-all of saying that something is working, but this is not a bad measure to see if PQCs have had an effect. And now with 50, 60 publications of PQCs out there, I think it's pretty solid evidence that these collaboratives result in real improvements. These are several of your Tennessee publications. I thought I had them all, but I missed a couple. I read this slide. But you guys have been leading the way in publications. And importantly, PQCs are getting better at this. And what I mean by that is they are getting better at using rigorous QI to do improvement work, right? So what are some examples? So focusing on better PDSAs. I have several examples from you guys, actually. Here's an example from your article about your breastfeeding project. So you might be able to see this. This is 10 steps to breastfeeding. The first column is how many centers submitted data for a PDSA cycle. But you didn't stop there. You also looked at the reliability of doing that activity. So how many centers had at least a 90% reliability on that activity? And early on, it was very few, but by the end, it was a lot more. So you didn't just focus on doing PDSAs, you focused on doing PDSAs well. Sustainment, a big challenge in QI. If you're a QI person, you know this. QI works. We focus on something, we see an improvement. The challenge is how do you sustain that improvement? Once you take your eye off the ball, how do you sustain it? Very few QI publications out there address sustainment. This is your publication from your resuscitation paper that just came out last year. You explicitly included sustainment periods in your QI project. So you had a baseline, implementation, refinement, but then a planned sustainment phase that showed that you're maintaining the gains. A lot of QI projects don't have that. You need to do better at this area. Rigorous statistics. We know that data over time is the best way to look at QI data, but it's not just data over time. You got to have it in a way that we can really understand the patterns of data over time. So one way is control charts. Here's a publication from California that showed examples of control charts the outcome was length of stay from 3 different hospitals in the project. And I'm not going to get into the details of this, but each of these showed a different pattern of improvement that really spoke to what was happening at that hospital. A lot of single-center QI projects don't use this kind of rigorous data analysis to understand what's happening, but PQCs can help with that. Another publication from PQC. The other approach to data analysis, so control charts is one idea, one approach. The other kind of rigorous way of looking at data over time is the interrupted time series analysis. Very few QI publications out there use interrupted time series. PQC did. This is your publication on early elective deliveries, and what ITS does, interrupted time series, it looks for background trends and the impact of your intervention on changes over time, accounting for those background trends. So I'm going to say collaborative QI, it makes single-center QI even better by helping all of us use more rigorous methods to do the improvement work at our own sites. All right, so the last thing, work at the population level. So at the end of the day, by definition, improving perinatal outcomes across a population should be the goal of state-based PQCs, right? You guys are the Tennessee initiative. That means you care about the moms and babies in all of Tennessee. Same in Massachusetts. Not at hospitals, but all the moms and all the babies. So how do we achieve kind of population level improvement? How do we take QI at the single center at the hospital level and try to look at population level changes in our outcomes? So to answer that, we need to think about the data sources for PQCs. And there's 2 main data sources. So one is clinical records data, so data we abstract from the hospital record. And then 2 is administrative data, so state-based vital stats data. So how can each of these data sources help PQCs move from hospital level QI to population level QI? So clinical data, this is from the chart. It's probably the most useful data because this really gives us the most accurate depiction of what's happening to our patients, but it's labor intensive to obtain. You know, somebody's got to go look at those charts and enter into data form. And I bet a lot of people in this room are responsible for doing that for your projects. It can be near real time. You can get data from patients born last month and put that in the database and get reports, you know, this month or up to last month. If you want to get to population level improvement, what you got to do is you got to engage as many hospitals as possible, right? Once you start getting into 70, 80, 90% of the hospitals in the state involved in your project, then you're getting pretty close to measuring population level changes. I know at PQC some of your projects have gotten there. You use comparative data to drive improvement, and then you track improvement across all of your hospitals. If you're using administrative data for population QI, this is, I think, newer for PQCs. Most PQCs started with that chart abstraction data. This is vital stats. It's already being collected. It already measures the entire population. The reliability is uncertain. We know that some of this data is not so accurate. You know, several states have looked at antenatal steroid rates using birth-specific data, and those rates we know don't reflect what's actually being given. The measured definitions sometimes are not exactly what we need. Timeliness can be tough. Usually vital stats are a year or 2, maybe even a little more behind the current period. Some states have done good work to try to improve the timeliness, and numerous OB projects have used administrative data rather than chart abstraction data to drive improvement and measure the impact across the level. I'm going to show you one quick thing we did in Massachusetts using administrative data, which we think is going to be pretty useful. So we made an NAS dashboard. I know you guys are working on this, and you may have something similar. I didn't see it, so you might. But what we did is the state took administrative data from a few different sources. We thought about important measures, and they came up with a list of measures which they could track just using vital stats data. So for example, we are really interested in EI referral for NAS, which, as we heard this morning, and I know you guys are focused on this as well. So we could track referral to EI, so how many babies with NAS were referred to EI within 6 months of birth. This is by year, 2012, 2016, and our goal was that all of these babies should be referred. And you can see we're getting better. 40%, we're up to, what is it, 75%? So that's not bad. I don't know why this isn't 85, 90%, but we're getting better. But we could also look at EI enrollment, right? So not just referral. The enrollment on the right side, you can see that's 30 to 40%. We're getting better, but that's quite a bit lower. So we were focusing on referral to EI, but that's only half the battle. We know that once you refer, half the families don't actually enroll in EI. So we have to figure out that piece, right? What is the break there? Why does referral not lead to enrollment? Once you start digging into it, you find a number of things that are potentially addressable. And finally, just real quick in the last couple minutes, we're all interested in disparities. We know that even when our outcomes are good, one area where it's not good is equity. So PQCs can help with this. One way is PQCs can identify disparities. This is that same NAS dashboard at the state level, looks at a couple outcomes by race. The blue line, the dark blue line is white. The light blue lines are black and Hispanic. The orange line is other and missing, so ignore that one. But you can see on the left, the rates of opioid use disorder and pregnancy. There's differences, and we know this. The rates are higher in the white population than in the black or Hispanic population. But if you look at EI enrollment, there you don't really see disparities. So once we engage the families and get them referred, the follow-through is pretty similar. So here's one area where we're not seeing too much disparities, which is a good thing. But in other areas we are. We use the same data from that project. This isn't the state level data, this is our clinical data now. And we looked at what are the odds. So this is our NAS project. The denominator is all babies exposed to opioids during pregnancy. And so we said, by race, what are the odds that that mom was on MAT, that the exposure was MAT rather than other opioids? And we saw an impressive difference that we didn't expect. So compared to white moms, our black and Hispanic moms, there weren't that many. There was a much bigger white population, we saw earlier. But the odds of the black and Hispanic moms being on MAT was substantially lower than the white moms, even adjusting for a bunch of other factors. And other things weren't different. EI referral, breast milk use, biological family. Once the parents were engaged, then things were similar. But getting into MAT was different. So are there barriers to getting black and Hispanic moms into MAT? The data is pretty convincing. And now we're starting to do some kind of more qualitative work, and we're seeing there are some real barriers out there that we need to start addressing. I'm going to skip these next couple of things. I'll just mention this one last thing. Yeah, we did look at, I guess I won't skip it. We did look at breast milk rates as well in one of our projects. 1 minute, perfect. And we saw that breast milk, this is breast milk in very low birth weight babies, Hispanic, black, white, Asian. Everyone starts up in the first few days of life giving breast milk, but then sustaining breast milk varies. And in particular, the Hispanic moms had a tougher time sustaining breast milk for the very low birth weight infants. Once we started talking to them, the reasons were pretty clear. Some of it was education, but mostly it was just real life. They were going back to work. They had a much tougher time being in the hospital. It was just real life things. So one of the things we can try to do, we can try to develop interventions to help this. These aren't great, but what we did is we developed some educational materials, which we made sure we put into multiple different languages. So Meg Parker led this work. It's incredible. If you go to our website, if you're working on breast milk, you'll see a bunch of family resources in many different languages, which you can download and use, both handouts and videos, which are pretty useful. And finally, this is the first publication I've seen about this. PQCs could actually reduce disparities. So California showed that when they implemented their maternal hemorrhage toolkit across the state, their differences, their disparities in maternal morbidity by race went down. So the blue lines are the rates before the project, the orange lines are the rates after the project. Across the x-axis of different races, you can see the differences decrease substantially after the implementation of the toolkit. So by improving quality for all populations, PQCs may be able to reduce these disparities. All right, so what do state PQCs do? They do a lot. QI education, I'd say that's pretty easy. It's not that hard to help your teams get better QI education. Supporting local QI efforts, I mean, getting a meeting together like this is not easy, but once you do, sharing and supporting each other, not that hard. Benchmarking, if you have access to data, that's not that hard. Collaborative QI projects, not easy, but not super hard. The population level work is hard, but it's worth it. So the last word is like, why should you participate? So you should participate, because listen, what you want to be this guy. You want to be driving the bus, all right? PQCs are this cart. They're moving forward. Don't be this guy. Don't be the one getting off the cart. Get on board, and let's all drive PQCs.